The problem with current practice in many intensive care units is an epidemic of deep sedation, bed rest, and immobility. As a result, when our patients survive their ICU stay, they're faced with many long-term ongoing problems with muscle weakness and often psychological problems and cognitive impairments, and we really need to change the paradigm in the ICU. The ICU rehab program moves to have our patients wider awake and moving, with early intervention to be mobilizing these patients and having them awake and interactive. At Johns Hopkins, we've had this approach to care for about a decade. So many years ago, we were really concerned about the growing problem of long-term physical, cognitive, and psychological impairments after critical illness. We had programs of research showing us that ICU survivors were regularly having problems in all of these areas. These problems have now become to be known as post-intensive care syndrome, or PICS. And a very important part of addressing post-intensive care syndrome is changing this paradigm of critical care practice. For hospitals to successfully implement an early ICU rehabilitation program, it takes designing, implementing, and conducting a structured quality improvement process. It requires putting together a team of people with multidisciplinary champions. It takes identifying barriers in ICU's own practice and thinking about customized solutions to those practices, and designing really simple metrics to help us understand how we're going to evaluate and measure progress. To be successful with this kind of structured quality improvement process, we offer a number of layered approaches to help make this happen. We have online e-learning modules to educate frontline clinicians and champions around the key aspects of these problems and solutions. We have an annual in-person conference where people from around the world come together to learn the latest evidence and the latest approaches. That includes workshops and smaller group settings, and very great chances to interact with the experts on our team. We also have a large toolkit of different practical things that hospitals can do to make this possible. We also have ways to evaluate how hospitals are doing in terms of metrics and ways for them to identify that things are getting better. We also offered a structured observership program that allows people to come to our setting to observe and see this actually happening, as well as meet with leaders to talk about how this might be implemented. In addition, we offer consulting where we can provide specific advice to other institutions and perhaps even go to the institutions to assist with organizing, planning, and implementing these programs. It's important to recognize that these changes are a growing shift in the paradigm of how we provide care every day in the ICU environment. This has been a program that we've been able to help many other hospitals successfully implement in order to improve their patient outcomes, and at the same time as reducing length of stay in their hospital. This is something that we've been doing for many years and found in our own hospital. This has been tremendously successful, and we've been able to help other hospitals have similar successes in their own settings.